Alright guys, so in today's video we're going to talk about alcohol use. So which objective I'm going to show you is resonating with this topic is substance withdrawal and substance use disorder. If you see the causes are chemical dependency, alcohol, illicit drugs, tobacco, prescription drug. So you need to know the clinical findings, or a thorough medical and family social history. See also substance related and addictive disorders, collateral history, physical examination, attention to mental status examination, autonomic instability, drug screening test, and the screening tools like MMSC, CAGE, and withdrawal assessment tools. You need to know the investigations to run, the liver function test and radiography, supportive measurement in the management like airway fluid, resuscitation, pain management, hospitalization, recovery, appropriate pharmacological intervention like thiamine, long-acting benzodiazepine, sedations, and specialized care like addiction programs, family counseling, mental health services. So let's go and start alcohol from this is the family medicine chapter, and you have to cover alcohol from two different chapters, actually three different chapters. One is from family medicine, second is from psychiatry, and the third is from emergency medicine. So three aspect if you cover alcohol from, that would be covered then only. Okay, I have also made one video on alcohol use disorder. I will attach the link below in this video. So once you complete this video, make sure you watch that video as well, because that's a big video where I'm covering it from psychiatry as well as in emergency medicine, right? So what is alcohol use disorder? Diagnostic categories occur along a continuum. Epidemiology: 15% of patient in family medicine misuse alcohol, to 50% hospital admissions, 10% premature deaths, and 30% are suicidal. 50% of fatal traffic accident in Canada are alcohol related. So it's mostly related. Alcohol relates to the road traffic accidents and more likely to misdiagnosis in women, elderly, and patients with high socioeconomic status. So assessment: how do you do the assessment for alcohol? If CAGE is positive, further explore for possibility of alcohol misuse or dependency. Assess drinking profile. So let's look at this pink box on the right side. It says CAGE. So in CAGE you have to see CAGE questionnaire. Have you ever felt you needed to cut down on your drinking? Have you people annoyed by by criticizing your drinking? Have you ever felt guilty about drinking? Have you ever felt you needed a drink first thing in the morning as an eye opener to steady your nerves or to get rid of hangover? Two yes responses considered positive. So there are basically four questions in the CAGE questionnaire. If patient says yes to two of the questions, then that means the patient is has a possibility of alcohol dependence. So how would you remember this CAGE questionnaire? CAGE question is by C for cut, A for annoyed, G for guilty, and E for eye opener. Are you annoyed by when people criticize you on your drinking? G for guilty. Do you feel you're guilty about your drinking habits? E, you think alcohol is an eye opener for you, and you think you need to cut down on alcohol. So this is the CAGE questionnaire. And then if CAGE questionnaire is positive, further explore for possibility of alcohol use disorder or dependence. Assess drinking profile. Setting: in which setting do you drink? What time do you drink? Is there any specific place you go and drink? What occasions do you drink? And with whom do you drink? With your family, with your partner, with your friends? Impact on the family and work and life, social life. Quantity, frequency, and history. How many drinks per day? How many days per week? Maximum number of drinks or any one day in the past month. If identified positive for alcohol use disorder, screen for other drug use. Identify any medical or psychiatric complication like delirium tremens or withdrawal seizures. Ask about drinking and driving. Ask about past recovery attempts and assess the current readiness to change. So these are the positive. If let's say patient has come positive for after CAGE questionnaire, you need to assess for drinking and driving habits, other use, other drug use, and other psychiatric complications, and past recovery to attempts, and if the patient is ready to change. What investigation? This is one of the MCC objective. They're asking you about investigation, so you need to know that you're going to do gamma GT, MCB for baseline and follow-up monitoring. You'll also do liver enzymes, which are AST, ALT. AST approaches is 2:1. That means AST is 2 times higher than ALT in person with alcohol use disorder. And then CBC will show anemia and thrombocytopenia, low iron and low platelets. INR, decreased clotting factor production by liver. What are the interventions? Intervention should be consistent with patient motivation for change. Individualized counseling and regular follow ups is crucial. 10% of the patient alcohol withdrawal will have seizures or delirium tremens. Alcohol Anonymous 12-step program. Make sure you know these programs. Alcohol Anonymous or 12-step programs is actually programs which patients are going through these days. Like I see patients in clinic who are alcoholics and now they are trying to quit on alcohol. So they are enrolled in these Alcohol Anonymous programs. These are basically outpatient day programs for those with chronic resistant alcohol use disorder. They are family treatment, and there are examples like All Anon, Alateen, Screen for Spousal and Child Abuse. You also need to check if there's a child at home and if there's a history of abuse among the spouses. Refer to specialists and inpatient program if dangerous or highly unstable home environment, severe medical and psychiatric concern, addiction to drugs that may require inpatient detoxification, refractory to other treatment programs, pharmacological treatment like diazepam for withdrawal, disulfiram impairs metabolism of alcohol by blocking conversion of acetaldehyde to acetic, leading to flushing, headache, hypotension if alcohol is ingested. So basically, disulfiram is one of those drugs which is no longer available in Canada, but the action mechanism of action is that it blocks the conversion of acetaldehyde. That means if a patient consume alcohol, so it would not metabolize in the body and it would cause him flushing, headache, nausea, vomiting, hypotension. That means the patient will feel sick after drinking alcohol. Naltrexone is a competitive opioid antagonist that reduces the craving and pleasurable effect of drinking. So it reduces the pleasure that you get from drinking. Naltrexone is something that is available in Canada. May trigger withdrawal in opioid dependent patients. So if let's say if a patient is alcoholic along with he's an opioid dependent, so if you give him naltrexone, that would give him withdrawal symptoms if he's on an opioid. So that's one of the things that you need to remember. Acamprosate is a glutamate receptor modulator that also reduces the craving. So two drugs, naltrexone and acamprosate, they both reduces the craving, but naltrexone will give withdrawal symptoms if the patient is on opioid. Prognosis is relapse is common, should not be viewed as failure. Monitor regularly for signs of relapse. 30% of the patient with alcohol use disorder exhibit spontaneous improvement over 1 year. 70% of individuals with jobs and families have improved quality of life 1 year post treatment. So you need to know that there is some improvement in 70% of the patient with jobs and families. Okay. So if we go back and we see the boxes on the right side, standard equivalent drink, how much grams and how much ounces. You don't really need to learn it for QE1. Just remember that hard liquor has 40% of alcohol, whereas let's say beer or cooler has 5%, which is the least amount, but wine has 17%. So just remember which one has how much. Like you don't exactly have to remember the number, but just have an idea that hard liquor is the most strongest one and beer is the least strongest one. And the cage question is most important in this. And continuum of alcohol use, on the right side it says low risk drinking. So you have to remember the number of drinks. Let's say ideally for if the low risk drinking is less than 2 drinks per day, if less than 10 drinks per week for women and less than 15 drinks per week for men. So this is a low risk drinking. But at risk and drinking, consumption above the low risk but no alcohol related physical and social. At risk are those who are drinking above the level but they do not have any physical or social problems. But alcohol use disorder comes when the patient start having the physical and social problem. Let's say someone is drinking, let's say 3 glasses of liquor every day, and now he is having problem with his wives. He's being abusive towards his family. Then that's a physical and social problem. Now this is called alcohol use disorder. So continued use despite consequences, inability to fulfill life roles, legal problems, no evidence of dependence. Now he is having some legal problems. So this is now alcohol use disorder. Okay. Some adverse. So you need to know when is it low risk, when is it at risk, and when is it alcohol use disorder. So at risk means he has no physical or social problem, but he is at risk because he is drinking more than the required number of glasses of drinks. So less than 2 per day is ideal. For men it's less than 15. For women it's less than 10 per week. Okay. And if they have social physical problem, then that's a legal problem. That means he's now having alcohol use disorder. Some adverse medical consequence of problem drinking: GI causes gastritis, dyspepsia, pancreatitis, liver disease, bleeding, diarrhea, oral esophageal cancers. Cardiac, it leads to hypertension, alcohol cardiomyopathy. Neurological, it causes Wernicke-Korsakoff syndrome, peripheral neuropathy. Hematological, it causes anemia and coagulopathies. Other, it causes trauma, insomnia, family violence. anxiety, depression, social family dysfunction, sexual dysfunction, and fatal damages. So this is it for alcohol. For psychiatry part, that is covered in the link I will send you in the description below. Make sure you check that link, and then also cover alcohol use disorder from emergency medicine. Then your alcohol use or substance use will be covered from MCC objectives. Next video I will be making on common presenting problems in the clinics. So this is now going to be a very interesting videos that we will be following up. But make sure you complete alcohol from emergency medicine as well as psychiatry. I've attached the link in the description below. So make sure you complete alcohol use from that video as well. Thank you for watching. Please make sure you subscribe to my channel and comment down below if you have any questions. Thank you.